This video continues Chapter 23 of OEC 6, looking at chest trauma. And in this video, we'll consider the management of chest injuries. Now, for the management of chest injuries, our assessment does not change. We'll correct the ABCDs, provide high-flow oxygen if indicated, and monitor the O2 saturation level with the pulse oximeter, looking for something greater than 94% saturation, and call for transport with ALS. In the case of chest trauma, we're really considering an injury to the respiratory or cardiovascular systems, and so these can be very, very urgent. Consider transport in a case that will provide ease of breathing, oftentimes in a sitting position. If a patient does need spinal motion restriction, elevate the head of the backboard, maybe prop it up in the toboggan with a quick splint underneath. Now, some soft tissue injuries of the chest would be treated just as described in Chapter 19 of OEC 6, standard bandages and dressings. If they are bleeding heavily, we'll need bulky pressure dressings. One thing to consider is that if we have a rib fracture, the patient will have a lot of pain, especially when they're inhaling. We don't want to splint the chest because that would further impair the breathing, and we certainly don't want to put a constrictive bandage all the way around the chest to interfere with breathing anymore. Always consider that there may be internal organs that have been damaged in the case of a rib fracture. This could lead to something very serious, such as a pneumothorax. If the patient has multi-system trauma and a chest injury could be part of that, consider that this is going to progress very quickly to a life-threatening condition and could be a load-and-go situation. Correct the life-threatening condition and provide oxygen, and rapidly move the patient to higher care, preferably a designated trauma center. For the special case of commotio cordis, which we see in young patients, typically under the age of 16, who've been struck in the center of the chest, leading to cardiac arrest, we'll simply go down our CPR algorithm, including application of the AED. Commotio cordis can actually lead to VTAC and VFib as possible arrhythmias, and the AED will address this. For traumatic asphyxia, this is a case where the patient has essentially been crushed and they can't simply breathe. They're not able to expand their chest for inhalation. What we want to do is relieve the external pressure and allow them to start to breathe, and then aggressive ventilatory support, rescue breathing with a BVM if we needed to. For an avalanche victim, remove the snow or the other debris, make sure the airway is open and patent, using suction if necessary, and then call for transport and advanced care, and consider the possibility of other injuries such as pneumothorax or tamponade. We want to use high-flow oxygen if the patient's breathing efforts are spontaneous and effective. That high-flow oxygen will help keep O2 saturation between 94 and 99%. If the patient's own breathing efforts are not effective, we can assist using a BVM and the supplemental oxygen routed through the BVM. If the patient gets worse, you might have a tension pneumothorax, and that positive pressure from the BVM is actually making it worse by driving more air into the pleural space. For an open chest injury or sucking chest wound, we're going to want to cover the wound with a gloved hand, because that gloved hand is essentially a temporary occlusive dressing, an airtight blocking dressing. Even if there's no obvious sucking sound, we want to use an occlusive dressing on any penetrating chest wound. Now, there are several commercial products available: Vaseline gauze, Bolin chest seals, Asherman chest seals. There's also a hyphen one, which we can also replace with an improvised one, such as plastic wrap or aluminum foil or something that is airtight. We tape that occlusive dressing, the improvised one, on 3 sides. If I have some sort of an improvised dressing and I tape it and I tape it and I tape it, This open side can act as a flap, which will allow pressurized air during the patient's exhalation to escape. Keep monitoring, and in the case of respiratory distress, it may be that this flap is not functioning properly, so we want to readjust the dressing, essentially just kind of burp it so that air buildup does not continue inside the pleural space. Always remember that serious chest injuries are going to be load and go situations. You can apply cervical spine stabilization and rapidly immobilize the entire spine with a long spine board or vacuum mattress, and then go so that the patient can be taken to higher care. For a flail chest, which is 2 or more ribs broken in 2 or more places, we do not want to use a circumferential bandage. That can interfere with the patient's inhalation. We can stabilize those bones with a large bulky dressing such as a pillow, folded clothing, or a magazine, and isolate that paradoxical motion that can occur. The patient can hold the splint in place, and then we can secure it against the chest wall as we're able to. We can assist the patient's respirations with a BVM and O2, and if the patient won't tolerate the BVM, just use a high-flow non-rebreather mask set at 15 liters per minute. For the case of impaled objects, we're going to immobilize them as we do with all impaled objects, and we do not remove them. That could result in further hemorrhaging or a pneumothorax, or in extreme cases, exsanguination, literally bleeding out. If the impaled object is large, you may need to shorten it. In the case of a ski pole, many trauma packs actually carry a pipe cutter. If it's a tree branch, lots of times multi-tools have a saw that you can use. To shorten that object, make sure that the long arm end of it does not move, because that could cause further injury. If you needed to remove the object, this would be typically not our standard of care, but if there are rapidly deteriorating conditions and the impaled object is fixed, such as snowmaking equipment, you may need to just remove it so that you can load and go. Be ready to care for pneumothorax in this case and other life threats once the object has been removed. Preferred treatment, leave the impaled object in place. Transport will be in a head uphill position because that reduces pressure on the diaphragm and allows for easier breathing. In the absence of trauma, a patient with difficulty breathing, dyspnea, is typically best served by transporting them in the sitting position. We may consider, alongside spinal motion restriction, elevating the head to assist with breathing efforts. And finally, in all of these cases, chest trauma includes damage to, potentially, respiratory and cardiovascular systems, so expect shock. So keep the patient warm and provide oxygen. Shock is no longer a determining factor in the placement of the patient for transport. Elevating the legs is no longer recommended. Head uphill to assist breathing may be more beneficial for the patient. We can summarize some of our treatment this way: rapid care for the ABCs and support ventilation with O2 at high flow, 15 liters per minute, or a BVM if needed. Occlusive dressings on chest wounds will help minimize the effects of a developing pneumothorax. Immobilize the spine if a spinal injury is suspected, and in all cases, rapid transport, possibly by air, may be required.